Our concept is perfusion, and the exemplar is coronary artery disease, where we have impaired perfusion to the coronary arteries of the heart. Coronary artery disease is the most common type of heart disease and the leading cause of death in the United States in both men and women. Coronary artery disease occurs when the arteries that supply blood to heart muscles becomes hardened, narrowed due to a buildup of atherosclerotic plaque. As a result, the heart can't get enough blood or oxygen that it needs, which leads to chest pain, which is called angina, or a heart attack. Most heart attacks happen when a blood clot suddenly cuts off the heart's blood supply, causing permanent damage to the heart. You saw this slide under peripheral vascular disease explaining the pathophysiology of atherosclerotic lesions, but it applies here as well, affecting the coronary arteries. This slide shows that plaque can be either stable or unstable and rupture without warning, causing the sudden formation of a blood clot or thrombosis, which can lead to either total or partial occlusion of the artery. I have several short videos that will help you to understand and remember the pathophysiology of coronary artery disease. They are mostly short and well worth your viewing. Impaired perfusion to the coronary arteries can either cause ischemia, where there is an insufficient amount of O2 supplied to the myocardium, or infarction, where there is necrosis or cell death due to prolonged ischemia. Angina pectoris is a type of chest pain caused by ischemia that is limited in duration and does not cause permanent damage. Chest pain is further classified as either chronic stable or unstable angina. Chronic stable angina occurs with moderate exertion in patients with a stable or fixed plaque. The frequency, duration, and intensity of symptoms remain the same over several months. Chest pain results only in slight limitation of activity and is usually relieved by rest or by nitroglycerin tablets. Unstable angina is on the spectrum of acute coronary syndrome. It can occur at rest or with exertion and causes severe activity limitations. It may be characterized by an increase in the number of attacks and in the intensity of the pain. The pain or pressure may last longer than 15 minutes and be poorly relieved by rest or nitroglycerin. However, troponins and other cardiac biomarkers are negative, and ST changes are either minimal or not there. So it looks and feels like a heart attack, but we don't see other diagnostics indicating that infarction is occurring. Unstable angina is divided up into three categories. First, there is new onset angina, which is the first anginal attack that occurs with exertion. Second, there is variant or prinzmetal angina, which is chest pain caused by spasming of the coronary arteries. This usually occurs during rest between midnight and early morning hours. And lastly, pre-infarction unstable angina, which may occur days or weeks prior to an MI. And infarction or ischemia usually occurs when blood flow is reduced about 80 to 90%. This slide shows you that there is a spectrum of clinical presentations of impaired perfusion, from mild to moderate to severe, and mild can change to severe if and when a thrombus is released from a damaged arterial wall. So we say that chronic stable angina occurs with a stable plaque, leading to mild ischemia with exertion that is relieved with rest. Unstable angina is due to ischemia of different degrees to the myocardium and continues even with rest and/or medications. but has normal biomarkers. And then there is unrelenting chest pain with ST elevation, indicates infarction, necrosis due to prolonged ischemia, and this type will have positive biomarkers. So in review, acute coronary syndromes can range from ST segment elevation, myocardial infarction, which is a STEMI, to a non-STEMI or non-ST elevation, and then also unstable angina, which is also considered to be on the acute coronary syndrome spectrum, in which there is no detectable release of enzymes and biomarkers of myocardial necrosis. Causes of unstable angina are narrowing of the arteries, vasospasms, or dissections of the coronary arteries, and we may see transient ST changes with the unstable angina. We're not going to go into the STEMIs at this time, so we're stopping with stable and unstable angina as far as this topic goes. So if your patient comes in with chest pain, what information do you need to obtain during the patient history data collection? And this is like asking 100 questions, but everything is important, and patients don't always know what is important to tell you. So first off, we begin asking them if they're having any chest pain or tightness. Then assess the onset, location, and characteristics, what it was brought on by, any associated symptoms, what the pain was made worse by, or what the pain was relieved by. We're going to ask them if they have had any shortness of breath, orthopnea, fatigue, cough, cyanosis, edema, or nocturia. We need to also ask about their family history and personal habits. There are so many detailed questions to ask with an initial assessment that we usually have to have a form to go by. I will post a chest pain assessment form on Blackboard to help you see how detailed you will need to be. Asking questions is not only a part of your assessment, but also a way to gather information to do appropriate patient teaching about lifestyle changes that may need to be made. Classic symptoms of coronary artery disease include chest pain or pain in other upper body areas such as the arms, shoulder, or back, sweating, indigestion or heartburn, nausea or vomiting. They could have dizziness or rapid or irregular heartbeat. The classic signs usually are described as pain radiating on the left side, up to the jaw, also feeling like an elephant might be sitting on one's chest. Women with CAD may experience the classic symptoms that I just said, but they are also more likely to experience less commonly recognized symptoms such as unusual fatigue, sleep disturbances, shortness of breath, indigestion, and anxiety. Elderly patients more frequently have coexisting cardiac disorders, so many of them can independently feel or causing of angina or exacerbate angina due to any kind of underlying coronary artery disease. Diabetics also have atypical signs and symptoms of coronary artery disease. Making lifestyle changes can help prevent episodes of angina. Patients sometimes know what can bring on the pain, so we can do patient teaching to slow down or to take rest breaks if physical exertion triggers angina. Avoid large meals and rich foods that leave a stuffed feeling if heavy meals trigger the pain. Try to avoid situations that make people feel upset or stressed if emotional stress triggers angina, and to learn ways to handle stress that cannot be avoided. Medications that may be ordered for the treatment of angina include nitroglycerin to vasodilate the coronary arteries, beta blockers to slow the heart rate and allow for a longer diastole and thus longer time to perfuse the coronary arteries. They could use ACE inhibitors, which would decrease the volume of blood and lower blood pressure. Antiplatelets like a baby aspirin to inhibit clotting or the formation of a thrombus. And calcium channel blockers, which also relax and vasodilate the arteries. All of these medications can lower blood pressure as well, that is, except for the antiplatelets. Because signs and symptoms for unstable angina are similar to an acute MI, the protocol of MONA will likely be started while ruling out MI with other diagnostics. You can remember the interventions by the word MONA, M-O-N-A, morphine, oxygen, nitroglycerin, and aspirin, but they are not in the right order. First, we would put on oxygen because a major problem is that O2 is not being delivered to the myocardial muscle cells. However, we need to spot check the SpO2 first, as oxygen will only be given if SATs are less than 95%. Next, we would likely get them to chew the aspirin, whether it is the 82 milligrams or the 325 milligrams, and then after that, put the nitroglycerin tablet sublingually under the tongue to dissolve. Finally, if our blood pressure is good and the patient is still having pain, we might very cautiously give them the ordered morphine for continued chest pain. Lead EKG will be done stat to assess for any pathological changes. Some of the other diagnostic tests could include a stress test, either exercise or chemical, an echocardiogram, the nuclear scan, cardiac catheterization, or a coronary angiography. Cardiac biomarkers that are drawn to rule in or rule out an acute MI are on this graph. You can see the CK, CKMB, and troponin. Troponin is very sensitive and can be detected even upon very low levels. If initial markers are negative and have been measured within 6 hours of symptom onset, the biomarkers should be re-evaluated within 8 to 12 hours after symptom onset. So if our patient is diagnosed with unstable angina, biomarkers are negative, how can we help them to avoid a heart attack? There are several modifiable and non-modifiable risk factors for coronary artery disease that we can do patient teaching. The non-modifiable factors are family history and age, 45 or older in males and 55 or older in females. Modifiable risk factors include lipid panels with high LDLs, low HDLs, high triglycerides, hypertension, smoking, tobacco use, diabetes, insulin resistance, obesity, lack of activity, high sodium intake, and metabolic syndrome. Basically the same thing as in peripheral vascular disease. The main labs done to predict cardiovascular health or disease include the lipid panel of cholesterol, triglyceride, HDL, and LDL. However, newer and more predictive labs include the HS, or highly sensitive CRP. This test is different from the regular CRP test, which detects elevated levels of CRP in people with low-grade infections and inflammatory processes. New research has found that high normal levels of this highly sensitive CRP in otherwise healthy individuals is predictive of future risks of heart disease, stroke, sudden cardiac death, and peripheral arterial disease, even when lipid levels were within acceptable ranges. The last lab is L-lipoprotein A. It's an LPA, which has also been shown to be a causal risk factor for premature cardiovascular disease. The LPA level is genetically determined and remains relatively constant over an individual's lifetime. So he said that metabolic syndrome was a risk factor for any kind of peripheral vascular or coronary artery disease. And so to explain what that is, according to the American Heart Association, metabolic syndrome occurs when a person has 3 or more of the following 5 measures. And this is abdominal obesity, a waist circumference of 40 inches or more in men and 35 inches or more in women, triglyceride levels of greater than 150, HDL levels of less than 40 in men, less than 50 in women, systolic blood pressure of 130 or greater over a diastolic blood pressure of 85 or greater, which is hypertension, but that is not all that high. And then lastly, fasting glucose of 100 or greater. These greatly enhance one's risks of developing cardiovascular disease. Remember that primary prevention is preventing the occurrence of coronary artery disease. Lifestyle changes would include a low saturated fat diet with low or no added salt, increase in plant foods, decrease in starchy foods, and a decrease in dairy products. Exercise to maintain an ideal body weight or to decrease body weight if needed. Stress reduction, as stress causes narrowing of the arteries. Stop smoking because nicotine is a vasoconstrictor and also can increase hypertension. Secondary prevention is to prevent the progression of the disease, and that can be done by monitoring blood pressures daily, following a heart-healthy diet, being physically active, monitoring and maintaining a healthy weight, quit smoking, managing stress and learning to cope with stress, and then to take medications as prescribed, such as antiplatelets, antihypertensive medications, fish oil or antilipemic medications, also known as statins. Tertiary prevention focuses on minimizing deterioration and improving quality of life. Some measures that are considered tertiary might be having an angioplasty with or without a heart cath for diagnosed coronary artery disease, maybe a CABG for occlusions, or cardiac rehabilitation after hospitalization. What medications can be used to lower cholesterol, and what are the major effects of each, and what considerations need to be taken into account? Statins are the first-line treatment for most patients because they are the only cholesterol-lowering drug class that has been directly associated with reduced risk for heart attack and stroke. They block the production of cholesterol in the liver itself, and they lower the LDLs, or the bad cholesterol, and the triglycerides, and they have a mild effect in raising HDLs, or the good cholesterol. Side effects usually include muscle inflammation, cramps, muscle soreness, pain and weakness, intestinal problems such as constipation, nausea, diarrhea, stomach pain, possible even some liver damage. And so I've given you a list of the most common ones that are used. Next group I'm showing you is the bile acid resins or sequestrants. These are the oldest and safest lipid-lowering agents, but they are less potent than the other classes now available, and they are not always well tolerated. The common side effects for these are upset stomach, constipation, gas, bloating, and nausea. And I have the generic and brand names listed here for you. Fibrates are the last group I'll mention. All of these different classes lower cholesterol, and all have side effects of abdominal issues, muscle issues, and sometimes liver issues. It's very important to control hypertension to reduce the risk of coronary artery disease, but we will discuss these different medications when we are looking specifically at hypertension.